Hi, welcome to Student Nurses Success, where we're going to cover electrolyte disturbances today. The electrolytes we're going to discuss include sodium, potassium, calcium, magnesium, and phosphorus. I'd like to say a few things about electrolyte disturbances before we get started. First, we will talk about some manifestations of each of them, but a lot of the manifestations are vague, like weakness and lethargy, and often the same manifestations appear in different electrolyte disturbances. So it is of utmost importance to have lab values to verify the disturbance. Therefore, you're going to need to know the normal lab values for each of these, and you can see them right here. Hormones can affect electrolyte levels. For example, epinephrine and insulin infusions can decrease potassium. Medications can also affect them. Some diuretics decrease potassium, while others increase potassium. And we know that SSRIs are often implicated in decreasing sodium concentrations. Over the counter laxatives and antacids can also alter magnesium levels. We also know that electrolytes are lost in urine, feces, and sweat, so patients with diarrhea and vomiting can lose potassium and magnesium in particular. It would probably be helpful to review the video on fluid balance, as fluid volume overload and fluid volume deficit can alter electrolyte levels. Let's get started with our blank map. Remember, the link to the maps is found in the comments section. We will begin with sodium. Sodium enters the body through the GI tract and primarily leaves by way of the kidney. The kidneys excrete or hold sodium depending on sodium intake. You have baroreceptors in your blood vessels that detect the stretch of the vessel wall. And when the circulating volume is down, the stretch is less, so the body conserves sodium to increase fluid volume. It does this by acting on the renin-angiotensin-aldosterone system, which causes you to retain sodium, and water follows with it. We also know that changes in osmolality trigger ADH release and thirst to increase fluid volumes. Sodium is primarily an extracellular electrolyte and it controls water distribution. This is an important concept. Now, hyponatremia or low sodium means that there's not enough sodium outside of the cell. So in this particular case, water from the outside moves into the cell to balance, leading to cellular swelling. Hypernatremia, or increased sodium, means there's too much sodium outside the cell. In this case, water from inside the cell moves out of the cell to try to balance, causing the cell to shrink. Now let's talk more specifically about hyponatremia and the causes and manifestations. Causes of hyponatremia include fluid volume overload and anything that causes fluid volume overload, such as heart failure. Fluid volume overload dilutes the amount of sodium available. We also know water intoxication or excessive D5W infusions will also cause hyponatremia. When you infuse D5W, the dextrose is metabolized off, and so what you're left with is infusing almost like pure water. We know SSRIs are also a cause of hyponatremia, and if you just have a loss of sodium. Manifestations of hyponatremia include a sodium level of less than 135, and in some cases, you may, if it's a dilutional hyponatremia, meaning you have fluid volume overload that's making your sodium levels low, you will also see a low hematocrit. Other symptoms include nausea, vomiting, cerebral edema, lethargy, headache, seizures, and weakness. Remember, in hyponatremia, we end up with the cells swelling, and that's where we get that cerebral edema. Now let's talk about hypernatremia. Causes of hypernatremia include fluid volume deficit or dehydration, where that actually concentrates the level of sodium. In some cases, patients who receive tube feedings or a lot of formula feeds without adequate water are getting over-concentrated with electrolytes. We also know excessive water loss or excessive sodium intake can cause increased sodium levels. And deficiency in ADH can lead to hypernatremia. Manifestations of hypernatremia include a sodium level of greater than 145, concentrated or high hematocrit, thirst, oliguria or decreased urine output, restlessness, headache, seizure, and tachycardia. A lot of these manifestations are related to fluid volume deficit. With hyponatremia, a lot of the manifestations may be related to fluid volume overload. Again, your normal sodium level is 135 to 145. Let's talk about potassium. Potassium primarily resides inside the cell. It plays a major role in muscle contraction and nerve impulse transmission. It also plays a big role in EKG rhythms of the heart. Therefore, either hypo or hyperkalemia can both result in arrhythmias. Aldosterone is a big regulator of potassium as well, and increases in aldosterone can actually lower potassium and raise sodium. Kidneys are how potassium is regulated and removed from the body. Therefore, patients with kidney or renal disease or renal failure have increased potassium levels. Now let's talk about hypokalemia. Common etiologies include loop or thiazide diuretics, GI loss, hyperaldosteronism, steroids, alkalosis, low magnesium levels, or insulin infusions. Manifestations include a potassium level of less than 3.5, metabolic alkalosis, arrhythmias, including ectopic heartbeats, and that's important, muscle weakness, and decreased bowel sounds. Let's talk about hyperkalemia. The biggest cause of hyperkalemia includes renal failure. Other causes include hypoaldosteronism, Addison's disease, which lowers aldosterone levels, ACE inhibitors or potassium sparing diuretics, trauma, and metabolic acidosis. Let's talk a second about trauma because that sounds a little unique there. The problem with trauma is when you have trauma, you have cells that break apart. When cells break apart, they release potassium. This is something that if you have a traumatic blood draw, meaning maybe when you drew the blood, you actually damaged a lot of the blood cells, the sample will come back as very high in potassium and it's a false elevation. Or sometimes they will actually say that the blood specimen is hemolyzed, which means you need to redraw it because it's not getting an accurate reading. Manifestations of hyperkalemia include a potassium of greater than 5.0, metabolic acidosis, weakness, cramps, Slowed heart rate. So again, you see these arrhythmias, ventricular arrhythmias, and cardiac arrest. In both cases, we have these arrhythmias. And so it's extremely important that when you have hypo or hyperkalemia, that your patient is monitored and put on cardiac monitoring so that you can monitor their EKG heart rhythms. Again, normal potassium is 3.5 to 5. Now let's talk about calcium. Most of the body's calcium is stored in the bones. Calcium plays a role in nerve impulse transmission, cardiac muscle function, and skeletal muscle function. Vitamin D is also very important as vitamin D increases the absorption of calcium from the intestines. Your kidneys convert vitamin D, so your kidneys play a role in calcium. We also know that parathyroid hormone regulates calcium and parathyroid hormone actually increases calcium levels. So parathyroid hormone leads to increased calcium levels. And how it does that is it pulls calcium out of the bones to make it more available. With calcium, there's actually two blood levels, and you can kind of see them here. 4.5 ionized and 9 to 11. The ionized blood level is what is free and available. It is unbound. Ionized calcium level is the best indicator of available calcium in the body. So let's talk about low calcium and high calcium. Causes of hypocalcemia include low parathyroid hormone or hypoparathyroidism, neck surgery, which can cause hypoparathyroidism. High levels of phosphate actually will drive down calcium. So when calcium is low, we see increased phosphate, and they have that relationship. We also know that when calcium is high, we will actually see decreased phosphate levels, and we'll talk about that in a moment. Renal failure is also a cause of hypocalcemia because it causes reduced vitamin D. Infusion of excessive blood products would be the other cause. Blood products are preserved with citrate. And if patients receive excessive blood infusions, they receive large amounts of citrate, which can actually lower calcium levels. Manifestations of low calcium include an ionized level of less than 4 or a regular level of 9 or less. Other manifestations include tetany, circumoral paresthesias or tingling, laryngospasms, cardiac arrhythmias, bone fractures, and Trousseau's or Chopstick signs. So these are all symptoms of excitability. Now let's talk about hypercalcemia. High levels of calcium can be caused by hyperparathyroidism or too much parathyroid hormone. Some malignancies can actually release high levels of calcium into the bloodstream. Immobilization or non-weight bearing status, when patients are not bearing weight, it actually can actually raise their calcium levels. Lithium, oversupplementation of calcium, and vitamin D. In both of those cases, you can raise your calcium levels too high. Manifestations include ionized calcium greater than 5 or a regular calcium level of greater than 11. Other manifestations include muscle weakness, lethargy, decreased deep tendon reflexes, and arrhythmias. What you should note here is in both cases, EKG changes or cardiac arrhythmias are manifestations. So again, when you have altered calcium levels, you should have your patient on a heart monitor. Now let's talk about magnesium. The normal magnesium is 1.5 to 2.5. Magnesium is primarily held in the bone matrix. It is important for enzymatic reactions and for the use of ATP. Kidneys are the primary route of excretion for magnesium. We know that magnesium works with calcium and potassium and tends to move as the same direction as these. So when you have low calcium, you have low magnesium. When you have high potassium, you have high magnesium. We know magnesium plays an important role in blood pressure control. And we know that low magnesium causes increases in blood pressure. Likewise, we can use magnesium infusions to lower blood pressure, and we do this especially in pregnant women who are preeclamptic. Let's talk about low magnesium levels. Causes of low magnesium include GI losses, diuretics, which causes the loss through the kidneys, malnutrition or a decreased intake of magnesium, and alcoholism. Manifestations include magnesium level of less than 1.5, cardiac arrhythmias, hypertension, tetany, seizure, low calcium, and low potassium. And in fact, you start to see a lot of the symptoms related to low calcium in the manifestations. But this hypertension and arrhythmias is important. Now let's talk about high magnesium. Causes of increased magnesium are usually related to either supplements, such as over-the-counter laxatives and antacids, or renal disease, where the kidneys are not excreting any magnesium and it's starting to build up. We also see tumor lysis syndrome as increasing magnesium levels. Sometimes tumors release a lot of, the tumor cells break up and release a lot of magnesium into the bloodstream. Manifestations include magnesium levels of greater than 2.5, lethargy, weakness, respiratory depression, low blood pressure, and here we go, arrhythmias again. And we've got this low blood pressure. Again, we know that high magnesium seems to correlate with increased calcium levels as well. So you start to see those same manifestations. We also see some of the manifestations related to um, increased potassium levels. In both cases, again, we're worried about EKG changes or arrhythmias. And remember, magnesium infusions can lower blood pressure. So in some cases, when patients have high blood pressure, we can give them magnesium. The last thing I want to talk about is phosphorus. Phosphorus plays a role in cellular metabolism and helps form ATP. It is excreted through the kidneys, so renal failure may lead to increased phosphorus. Parathyroid hormone lowers phosphorus by increasing renal excretion of phosphorus. We also know that phosphorus and calcium tend to have an inverse relationship. So when calcium is low, we know that phosphorus is high. And when calcium is high, we know that phosphorus is low. So in these particular cases, we know that the etiology and the manifestations tend to be inverse of calcium. So if your patient has high phosphorus, their manifestations would be the same as low calcium. And if your patient's got a low phosphorus, their manifestations would be the same as hypercalcemia. And that's just an easier way to remember it. Normal phosphorus levels are 2.5 to 4.5. And there you go. You are finished with your map on electrolyte imbalances. Thanks again for joining me, and remember to subscribe and like the channel so that you are up to date on all our new videos. Have a great day.